All of our productions at GCTV are sponsored in part by Bay State Health, providing the care you and your family need when you need it close to home. Visit them online at baystatehealth.org. Greenfield Savings Bank. Visit them at 400 Main Street in Greenfield. Call them at 774-3191 or go online to greenfieldsavings.com. Greenfield Community College, providing access and excellence in higher education in the Pioneer Valley. Visit them at gcc.mass.edu. The Hammond Family. The Hammond family are longtime supporters of Greenfield Community Television. New Fortune Chinese Restaurant on the Mohawk Trail in Greenfield. Visit them online at newfortunema.com. Call them at 772-0838 and check them out on Facebook. Real Cleaning Services, cleaning Hampshire and Franklin County since 1972. We don't cut corners, we clean them. Check them out online at realclean.com. Call them at 413-422-1143. People's United Bank, located at 45 Federal Street in Greenfield. You can call them at 774-3713 or visit them online at peoples.com. The Solar Store of Greenfield, replacing fossil fuels and nuclear power one home at a time. Visit them at 23 Fisk Ave. Call them at 413-772-3122 or visit them online at solarstoreofgreenfield.com. Thank you to our sponsors for supporting all of GCTV's productions.
My name's Lisa Ahbel. I'm a registered nurse. I'm really intensely interested in advanced directives. It's a rich, contested, difficult, juicy subject. There are legal issues, there are medical issues, and it's complicated as all get out. And I figure if it's complicated for me, not because I'm brilliant, but I'm a nurse and this is what I study in my spare time. If I find it complicated, even doing all this study, it's complicated for everybody. So I'm glad you thought it was a good idea to come this evening. It's nice to have sort of a quorum of people so you can have a spirited discussion about things to discuss. Last time, 2 weeks ago, we met plus a few other people and talked about the healthcare proxy. So I just want to revisit that a tiny bit because it's really, really, really important. The overarching subject matter here are advance directives, which would indicate that you're talking now about something to prepare for something that's coming in the future, and hopefully, God willing, it's the far future, but you never know. We all know we're going to die, but that's the only certainty there is. You don't know when or how. So the healthcare proxy is something that everybody over the age of 18 needs. That's where you designate someone who will speak for you if you cannot. Now, the healthcare proxy is a legal form, but it lies dormant until you are unable because you're in a coma or you're sick or you're anesthetized or whatever, and you can't fully engage in the conversation about making decisions for your health care. All right, does that make sense? It gets turned on, literally switched on, with a written document from a physician who says, Marjorie can no longer make, or at this time, cannot make decisions for herself. Maybe I'm in a car accident and I'm temporarily in a coma. Well, when I come out of the coma, I don't need a healthcare proxy anymore because I can be my own advocate. But for that time when I'm incapable of speaking for myself, I need a healthcare proxy. And if you don't designate one, you designate one plus an alternate. You can even do two or more alternates on this form that you can download off the internet. I have extra copies here if anybody wants to see it. You get two yet other people to sign it. You could fill one out right now if you knew who your healthcare proxy should be, and two of us would witness it, and there you have it. If Terri Schiavo had had a form like that, we would never know who she was. Same with Karen Ann Quinlan, although there were no healthcare proxy forms for Karen Ann Quinlan and Nancy Cruz, and they sort of, those cases kind of showed the necessity for advanced directives. But Terri Schiavo could have had one and she didn't. And I don't know if you guys remember what a circus that was with Jeb Bush getting involved, and the president, and the Congress, and the right to life people, and her feeding tube was taken out and put back in 3 times over many years until finally her husband prevailed. So it's a classic example of how things can become a real mess. Fight between her husband and her parents. Again, if you designate one healthcare proxy, then they get to make decisions, and the other people can be unhappy about it or complain, but legally they can't file the suits that Terri Schiavo's parents did end up filing. I mean, hundreds. There were just countless suits and countersuits and, you know, rebuttals, and went to Florida Supreme Court and then the United States Supreme Court. I mean, it was a big deal. It was a horrible deal. I mean, it's nothing any family wants to go through. So that's a cautionary tale for why we need a healthcare proxy. And a healthcare proxy is indeed an advanced directive because it's not active right now. It's just in case, like you put on a seatbelt just in case you have to hit the brakes too hard, or you know, another car, God forbid, hits you and you don't want to fly out the window and die. You want your life to be saved. Now, how many of you wear a seatbelt every time you get in the car? How many of you have ever had your life saved by wearing that seatbelt? Because, all right, 2 of us, but the rest of us, and may never need the seatbelt, right? But we put it on anyway. Why? Because it's a really good idea. And it's the same with the healthcare proxy. Because once you're unconscious, or God forbid, I'm going to say God forbid a lot because it's like, let's not invite disaster here, right? Or I could go, puh, 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 like they, you know, whatever, to break the curse. Once you're too demented to know who you are or who your loved ones are, or you're unconscious, it is too late to fill out a healthcare proxy. It doesn't matter if everybody else in your family knows who you would have chosen. Once you can no longer be of sound mind to sign that paper, that ship has sailed, and then it's going to be a court-appointed guardian ad litem or something like that, which, as you can only imagine, is time-consuming. You lose opportunities. It's another big dramatic mess. So, yes?
So if, this is just because I'm trying to keep this clear in my head. So if husband loses his mind, wife is incapacitated for some other reason, and they only have 1 child, is the court then, or does that 1 child get to speak because they're the closest family?
Usually,
Or
but
do
it's...
you still have to go through that?
No, you should have a healthcare proxy,
Yeah.
because
No, but I
if
don't-
you're
that's
trying
very
to
important.
deal with a MOLST form, you better have a legal healthcare proxy designation in your hand. Otherwise, it's up to the individual hospital, the individual doctor, what they decide they want to do, and you don't want to leave these things up to chance. You can both have the same healthcare proxy. I mean, one person can be the proxy for lots of people. So it's not like wait, you mean you got Jimmy to be your healthcare proxy? No, I can't have Jimmy be mine. It doesn't work that way. A child, I mean, our son is
Jimmy can.
exactly. For my husband and me, our son is, for both of us, our primary, and our daughter is our alternate healthcare proxy. So that's just how it worked for us. The nearest and dearest loved one is not always the best choice for your healthcare proxy. I mean, if you really want no crazy measures taken and you don't want to be on a ventilator or a feeding tube or whatever ad nauseum or ad infinitum, then you don't choose the person who couldn't put down the dog to be your healthcare proxy. And sometimes that means not your spouse. It could mean it's your brother or your sister or your cousin who's a nurse or a child. So it's not about who your closest family member is. It's who do you think is most able to listen to your wishes and then to carry them out if you are not able to make those calls on your own. Does that all make sense? It's so easy to do, and if you miss the window, it's just got bad consequences.
And I liked your point about making 50 photocopies and tucking them everywhere.
Yes, so if you do have a healthcare proxy form filled out, make a ton of copies, give them to the healthcare proxy, have one at your doctor's office, file one at your nearest hospital. We keep ours in the glove compartment of our car. Just everywhere you can think of, or give it to somebody who you're close to. the more the better, because you want to be sure that whoever is the proxy has it in their hands when they're maybe coming to be with you at your bedside at the hospital and need to make decisions. Yes?
I read somewhere that if, I don't know how they would know, but the EMTs are required to try and resuscitate, and they walk in and they don't
Not if you
know.
have this.
They call a doctor first?
They don't need to call a doctor. If you have this on your refrigerator, this is the only thing that will call off the dogs. And it also brings up the question,
Just you carry it with you.
Do-
You don't know where your refrigerator's gonna be, right?
ish. There are issues here. Hi, welcome. Let me
I'm
begin
sorry, I
to-
jumped in with that, but.
You
I'll get
did,
back to it.
but we'll get back to it. We were just discussing healthcare proxies to kind of get us in the mood.
Okay.
Do you have a healthcare proxy? Do you know what they are?
I am one.
Okay, do you have one for yourself yet?
Maybe.
Okay.
This is my sister. My mother has a healthcare proxy.
All right, honey, you need a healthcare proxy. She will tell you all about it.
I'm
Okay.
taking notes. I got notes.
She'll tell you all about it. And I have the
Sorry.
forms here. Everyone 18 and over needs a healthcare proxy. Before you're 18, you're a minor.
Otherwise you
Your
get a
parents are
court-appointed person.
entitled to make those decisions.
Okay.
But once you're an adult, it's helpful to have a healthcare proxy. And what goes along with that is the notion that you have actually discussed with them what your wishes are, and in some manner of detail. Okay, so healthcare proxy form is a legal document that gets switched on when and if you're not able to speak for yourself, all right? Otherwise, it just sits there, because you're gonna make your own decisions, right? As long as you're of sound mind. The MOLST form, which stands for Medical Orders for Life-Sustaining Treatment, and every state has their own MOLST. I mean, every state, because the Supreme Court so decided, gets to decide how they're gonna handle advanced directives. And in Massachusetts, it's the MOLST form. This is really not an advanced directive, it's a present directive. It is a medical order that once it's signed by a doctor is like a prescription, and it starts being valid from the moment it is signed. Now, I have copied out this, it's on the MOLST website. There's a great Commonwealth website that has the MOLST form that you can download. I put mine on the pink paper. And it has this many pages of common MOLST misunderstandings. Now, the sort of the accepted theory is that no one needs a MOLST form unless you're near the end of your life. Like hospice-y, like within 6 months of dying or something like that. There's something to be said for that, because this is another way of telling you what it's meant to be full code. Have you ever heard that expression, your code status, or been asked, like if you get asked maybe what your mother's code status is? Full code means I say yes to everything on this form if it's necessary. Everything. If my heart stops, do CPR. If I stop breathing, put in an intubate me. If my kidneys are failing, dialyze me. If I can't eat with my mouth, put in a feeding tube. Intravenous feedings. It doesn't mean you'll get every single thing, but to the extent that any of the things I mentioned are deemed medically necessary, they will be part of what's suggested to you or done to you, unless you say no. So the MOLST form is a way of saying no. If you're saying yes to everything right now, as I am, I'll just speak for myself. I am full code at this very moment. Coming out as full code. So if I drop to the floor all of a sudden because I choke on whatever is still in my teeth from dinner, please revive me and call 911. Because I think my chances of surviving well are quite good. I'm in good health. I don't have any chronic illnesses. I think my chances are pretty darn good. Now, when I'm 90, I will probably have a MOLST form filled out, at least partially. Because there are probably things that I'm gonna think I don't want anymore, no matter what happens to me, okay? So that's the point of the MOLST form. And even though a lot of doctors, I mean, a doctor probably wouldn't wanna fill one out with me right now, unless I was darn sure, like I never wanna be intubated, or I absolutely don't wanna have compressions on my chest and, you know, be revived. It's way too early for me, because I'm still full code. However, I'll look at you just a second. I think it's really important to know what's on this thing, because every time you call 911, every time you go to the hospital, every time you have surgery or major medical interventions, you are saying yes, potentially, to everything on this form.
It's when you get the call.
Well, no, not every time you get the...
Jersey?
Well, anyway, that's why I think it's really useful to go through this and get a sense of what they are, because there's a lot of misconception out there about, especially something like intubation. Anyway, you were going to ask something.
Well, I was wondering, what does full code refer to, and what are the other partial codes?
Well, you get to decide what
Is there a
partial
zero
code is.
code? I mean, what are
Yeah.
those things?
No code is when you say no to everything on this form.
And that's what it would be called, is a no code?
Yeah, that's one of the things it's
Oh,
called.
okay.
Partial code means that you've picked and chosen, which you can do. You
So
can
those are like 3 designations that you would have?
It's a designation on a
Non-partial.
continuous scale, from nothing to everything. So it's not like, oh, I have to choose one. It's like a menu at a restaurant. You get to say yes or no to anything on here. You really do. You could start out saying, I know I don't want intubation, because I had that once when I had congestive heart failure. Never again. But if my heart stops, I want you to do compressions.
So I
And then
got that,
and then maybe 5 years later, you'll say, you know what? Now I don't want either one of those. And you can keep, it's an iterative process, you can keep changing it, and your healthcare proxy can, on your behalf, change it for you. So that's the other reason why a healthcare proxy is really important. Because, let's say, I mean, my mother was very demented at the end of her life. If I had been, I was probably my father was her primary healthcare proxy. He filled out a MOLST form on her behalf, according to what he knew of, what he knew her wishes to be. And he could have changed his mind on her behalf many times as well. So you'll see on the front, it says for the signature, you check off, am I the patient, am I the healthcare agent or healthcare proxy, or the guardian for someone who's too young. So any of those people can legally, if they're designated on the healthcare proxy form, like you guys, are you both healthcare proxies for your mom?
Yes.
So both of you are authorized, because of that form, if it's been switched on, to fill out a MOLST form for your mom and to streamline it and change it as her condition changes. So, but
Doctor has to turn it on. Doctor has to turn it on.
it does,
The
yes.
physician has to determine that she,
The physician just says, this patient is no longer able to make healthcare decisions on their own. It doesn't go into why. It's a very simple, straightforward form. And you can request it. If it hasn't been invoked yet and you're feeling like it's high time it was invoked, then you can request that from the physician of the patient who's in question. Okay? So what this form says, it says that it's a misunderstanding. It's not appropriate for every older person to have a MOLST form. It is, however, appropriate for anybody with a serious advanced illness. I.e., if you don't think you're full code anymore, then it starts becoming appropriate. Gesundheit. And usually, the ideal is that you discuss it with your primary care physician, or a physician, a specialist, or whomever that you really trust, and go through them, because the idea is they're going to advise you. Because there are medical questions involved with every single one of these. There's a really good reason to do everything on this form, and there's a terrible reason to do everything on this form. And I personally believe the more information you have, the better a decision you'll be able to make, and the better you're gonna feel about that decision that you make. All right, I wanna back up a little bit here and talk about why we're even talking about MOLST forms. Because up until the mid-1900s, there was no need to have them. Because people died naturally all the time. It was hard to keep someone alive, right? If they had a really bad heart disease or if they had a terrible infection, you know, there wasn't a whole heck of a lot that could be done. But now, since the 20s, we can intubate people and put a tube down your trachea and have it breathe for you. In the mid-50s, CPR was invented, and mouth-to-mouth resuscitation started becoming a thing that people were trained how to do. The first hospital ICU in the world was in Copenhagen in the mid-50s to handle polio cases. And I think at Dartmouth, I'm not sure what hospital this was, but in the mid-50s also in the United States, ICUs started becoming available in hospitals. And the intensive care unit is where you have patients who are intubated, who need, you know, the special pressor drugs to keep their hearts going, maybe telemetry. That's when they've got you hooked up to an EKG, so someone at the desk can watch at all times to see what your T wave and your QRS complex is doing, and make sure you're not in AFib or VFib or any of those things that are not really consistent with living. Dialysis started in 1946. Pacemakers, the first implantable pacemaker was placed in 1960. Cardiac monitoring started in the 60s. The first heart transplant, 1967 in South Africa. In 1968, the first patient who actually lived over a year with a heart transplant. TPN, which is total parenteral nutrition. That is where you get your nutrients into your vein. It's got to be into a port because it's very toxic. It's caustic to your blood vessels. So it has to go right in your aorta so that your heart, so you've got this huge volume to disperse it in your body. But it is, if somebody can't eat and or their stomach isn't, or digestive tract isn't able to process any kind of food, the pharmacist will mix up a bag of nutrition just for you with all, that's formulated with all the vitamins and minerals and everything that you need, and it comes with a script, and it's, have you ever hung a bag of TPN? But anyway, it's a way of keeping somebody alive, right? And maybe temporarily it's a great thing. What if you have this huge bowel resection or something like that? You have an injury or you have surgery or cancer, and you just plain can't digest food for a while. Well, wouldn't it be nice if for a month or so or a few weeks there was an alternative so that you wouldn't die of starvation in the meantime until you healed enough? And it's the same with intubation. Sometimes your lungs are weak. You've got terrible pneumonia, you need help breathing. It's just for 4 or 5 days, and then you feel better and you're strong enough and they can wean you off the ventilator and you don't need it anymore. So as a stopgap measure, all of these things are really, really, really useful. It's when people get stuck on them for years and years and years that it starts becoming an ethical, moral kind of a dilemma. And the last one are feeding tubes. They've actually been around since Egyptian times, but they're really, like what we think of as feeding tubes, either nasogastric or they take a hole somewhere and put it directly into your stomach. That was in the 70s. And feeding tubes were what those 3 cases I mentioned earlier, Nancy Cruzan, Karen Ann Quinlan, and especially Terri Schiavo, all revolved around feeding tubes. So I would say that the 3 most important things for us to talk about tonight are CPR. That's the real short-term, immediate, oh my gosh, I have to do something now kind of thing. Intubation, which often goes with CPR. Very many people who need to be resuscitated are on a vent, at least temporarily. And then for the long term, the feeding tube is a really, really important thing to wrap your head around. Like, what do I think I would want, and under what circumstances? Because if you talk to your healthcare proxy about it, then that's how you get your wishes carried out later on in your life, especially if you're not capable of making those determinations or saying, here's what I want, remember me? So that's the overarching picture. So CPR, how many people here have taken, CPR class? Everybody, look at that. So yeah, you've got to do how much? 2 inches, right? You're supposed to depress the chest 2 inches with every push, and it's supposed to be 100 times a minute. And imagine a crunchy little twig of a lady and what would happen to her ribs, or a man for that matter. So again, can save somebody's life. And I personally know somebody who would be dead right now if some guy in a truck hadn't passed by when he collapsed, and he had just finished taking he had just renewed his CPR, so he knew exactly what to do, and he kept Kevin alive. And Kevin's doing great now. Kevin's in his 60s. This happened when he was in his early 50s. So it is definitely a lifesaver. So on TV, like Grey's Anatomy and those shows, the overwhelming majority of CPR patients come out just beautifully. Like, hours later, they're sitting up and kissing their girlfriends, right? Because they're fine. Somebody actually watched and did a study, and 67% of TV resuscitations are successful. Yay, TV resuscitation. In real life, however, it's a much different story. 15 to 20% on average are successful. And by successful, we mean people who are pretty much back at their previous level of functionality compared to right before they had their event, whatever it was. Okay? The purpose of CPR is to prevent sudden death. And it's best, it works really great if you're in the hospital already and they're right there ready to intervene with you. It works best with a witnessed situation where, like, I see you go down and I know it's only been 30 seconds, and we start those compressions and I say, you called it 911 and you timed the blah, blah. Someone else is there to help relieve me, and we are on it. Your brain will never be without oxygen. Your chest is going to hurt afterward. Your bones might hurt a little bit, but you're probably going to be fine. There's a very good chance you will be. CPR is not indicated for people who have terminal irreversible illnesses. The point is not like to revive you from dying if what you're doing is dying. We have this feeling of power and also of responsibility, like, oh, I'm killing grandma if I don't do CPR. Well, no, there's a difference between allowing someone a natural death and actually killing them. And that's a problem hospitals and doctors have sometimes. So this is where having the conversation with your healthcare proxy, and for the healthcare proxy to be very clear about what they think their person wishes. It's really important to have that in your brain. So listen to these percentages for the average rate now instead of the average rate we said is 15% of success for CPR. If somebody goes into ventricular fibrillation after having a massive heart attack, and that could be someone who's otherwise pretty healthy, but like all of a sudden something blows, 26 to 46% chance that they're going to have a really good recovery. Someone who's having an overdose, a drug overdose, it's more like 28%. Okay, but here's where it gets a little stark. Acute stroke, 0 to 3%. Just think about that. And I'm not done. A bed-fast cancer patient who spends more than 50% of their time in bed, going into cardiac arrest and needing CPR, 0 to 3% chance of any meaningful kind of recovery. End-stage liver disease, cardiac arrest, 0 to 3% chance after CPR of bringing them back. Dementia requiring long-term care, 0 to 3% chance of recovering anything remotely meaningful in your life. Multiple organ system failure, 0 to 3%. Unsuccessful out of hospital CPR, so i.e. they keep doing compressions and the person's heart just doesn't start beating on its own, maybe they don't have a defibrillator, 0 to 3%. Chronically ill elderly, 0 to 5%. So, I'm not saying this to depress anybody. We all, although it's probably is depressing, it's not going to bring you back to life if you're already half dead, right? Which if you're, I mean, sorry to put it that way, but you know, I'm gonna call it like it is. So, knowing this, do you feel like you're as likely or less likely to think that CPR is a good idea for an elder mother, shall we say? All of us have elderly parents or aunts or whatevers, or ourselves. Like, did this surprise you,
Yes,
these low percentages?
yes.
Right? So no one tells you this. And the problem is, when you call 911, those guys and gals are amazing. They are like machines, they know their business, and their whole goal, their whole mission is to get that heart beating again. So, if grandma has one of these on the fridge and it says, no CPR, then you want to think twice about calling 911. You can call 911, and maybe you just want comfort measures. Maybe you're freaking out because they're air hungry and it's not fun to feel like you can't breathe. But you better have this form in your hand and be like this at the door, like, dudes. Because it's their knee-jerk reaction. It's their job, right? So don't expect, when people get upset, like, well, the EMTs did CPR anyway. Like, did you have your MOLST form filled out, available on pink paper? No? Well, then don't get upset if they do their job. Really. And don't get upset if hospitals can't find the MOLST form at that moment, or some doctor overrides. Like, they might know that your wish, I'm going to just point to you guys because I know you've got this family issue with your mother. That's all I know, is that you have a mother. I don't know what the issue is. But the only thing other than a filled out MOLST form that can call off EMTs doing CPR is an actual physician talking to them and saying, stop. So you saying, look, I'm the healthcare proxy, stop, doesn't work. You need this. If somebody wants to be a DNR, a do not resuscitate, that's what we used to call it, right? Which sounds horrible. It sounds like let's kill grandma, doesn't it? Do not, it sounds horrible. It should really be, a lot of places call it AND, allow natural death, allow natural dying, right? So this is where we talked about this last time, when we 2 weeks ago when we talked about healthcare proxies, is that it's really helpful to try to foresee the turns in the road on the highway of life, right? If you don't make any other decisions, you're going to be on the superhighway to the ICU. That's just the way it is in this country. Someone will call 911, you'll end up in the ICU, you know, they'll do CPR, they'll bring you back, you'll be on a vent and whatever all else. I'm talking about somebody who's quite old and already has a lot of illnesses, chronic illnesses. If that's not what you want, then you need to plan otherwise. It's like planning a vacation. If you don't just want to do the rubber stamp vacation, you want to take the side trip to Barcelona instead of whatever, you gotta reserve it ahead of time. You have to know where to get off. Because you might not see that exit, and then it's behind you. It's really hard to back it up. Yes?
I'm out in the garden driving stuff around, which is
Yep.
good weather. My thing's on the refrigerator. My neighbor calls because he sees me keel over in the garden. Are they going to look for that, or do I have?
That's
to
a really good question. It's hard for me to say.
Why?
They're trained to look on refrigerators
They are.
or
Okay.
on the door, but if the neighbor's freaking out, and
Being helpful.
yes. Oh, there have been stories about how, like the Meals on Wheels person shows up in the 5 minutes when the daughter of the guy isn't there, and she has the MOLST form kind of like concealed because it's hideous, right? It's not like something you really want to have, it's not as pretty as some people's wallpaper or color choices, right? So no one could see it. The person sees the collapsed father of this woman on the floor calls 911. He was a DNR. But because the daughter happened not to be there, and because the MOLST form was not proudly and openly displayed, he got CPR. So stuff like that can happen, and that's the most frustrating thing. There are people who say, have it tattooed, you know. DNR. Somewhere.
What about, is the DNR, say you didn't get to the MOLST form, and you have the DNR?
Same thing.
DNR, I mean, they won't resuscitate you, but all the, so yeah. Just
Well,
trying to think, so-
here's what's interesting. This is what I learned sort of looking at this. So, A and B on this form, that's the CPR or the ventilation. It's for a patient in cardiac or respiratory arrest. That means your heart has stopped and or you are not breathing. And that's when these two are really indicated to save your life, right? Now look what it says for the rest of them when you look on the back page. Where does it say? Hang on. The other ones are more, they're more nuanced. You know, and you get to choose short-term or long-term, because this is not life and death here. Whether you have dialysis today or tomorrow isn't going to kill you. Whether you're not drinking water right away isn't going to, it's not going to be the end of your life. We have some time and space to think about these things. But breathing and heartbeat, those are the really important ones. So to me, they're kind of in two different categories. Does that address what you were
I'm
thinking
just
of at all?
I'm just trying to think of the whole scenario. So you have a DNR, but you have the MOLST. And so.
Well, wait. So this is a DNR right here.
Right, but
And you don't have, and you could just say, I don't want to be resuscitated, but do anything else that I need. So all you do is, so that would be a partial code. Someone asked about that, right? You can pick and choose. You could say, I don't want dialysis, and I don't want artificial nutrition, but I'm okay with artificial hydration, through an IV or something like that. You can
What
pick
I'm
and
saying is
choose.
if someone can just picture the scenario, they come in as a DNR on the fridge,
Uh-huh.
so they can't do CPR, and then you just start natural death. They honor that and not transfer you to the hospital and try to do anything else.
Well,
So
your
what if you-
problem might be that you need
Yeah,
oxygen.
it's-
Like my mother had this issue. She had a 4th-degree heart block and MS and very demented, end of life. My dad freaked out. The hospice nurse got there 5 minutes too late. He called 911. He just couldn't handle it anymore because he did not know what to do. But she had a DNR. So they took her to the hospital. They put her on some oxygen. They observed her overnight in the emergency room, and then they sent her back home with an oxygen tank, which she hated that nasal cannula. So she kept ripping that off, which made my father nutty. But because, thank God, they had this form filled out, at least it called off the chest compressions. Now, my father should never have called the hospital. He just should have had 5 more minutes. He should have called my brother, who lived 1 block
Should've called
over.
hospice.
Well, he did, but they got there later because they had other patients that they were seeing. She couldn't get there right away. Anyway,
Yeah.
we'll move on, but there are a lot of issues here. It's very nuanced, and that's another reason why a healthcare proxy is so important, because you as healthcare proxies, if you are, you're thinking, you're asking questions, you're saying, what's the long-term effect if we do this treatment? And what does this mean for quality of life if we do that treatment? You're going to ask those questions of the physicians and the EMTs and whomever, and then to the extent that you can decide, you're going to try to make choices that are aligned with your person's wishes. Okay? That's the whole, and it's a hard job because it's not necessarily your wishes. You might want your mother to live another 5 years, and she might be like, I'm done. Don't put me on a vent ever again. It's like having a shoe stuck in my mouth. It is. People say that a lot. And also, you can't talk when you're on a vent. You can't drink when you're on a vent. You often need to be sedated because it's so very uncomfortable to be on a vent. If it's going to have to be for more than a week or 2, then they tend to do a tracheotomy and put the hole here so that at least then, you have use of your mouth again and you can talk and you can drink and stuff like that. For temporary, it could save your life and be wonderful. I mean, I'd put up with it for 4 days if it was the only way I could save my life. You know, if I were having this huge lung infection or bird flu or something like that. And I say this as somebody who uses naturopathic remedies, who goes to the acupuncturist, who had 2 home births. So I'm not somebody who just rushes out to take every drug known to man. But to save my life, I put up with 4 days of extreme discomfort on a vent, right? But would I want to be on one like Terri Schiavo? Would I want to be on one for 2 years in a persistent vegetative state? Hell no. I definitely would not. So I think actually those the extreme examples of like, let's say the traumatic car accident, you know, where I hit my head and they know that my EEG is shot, and I go into a persistent vegetative state. What would you want to do in that situation? That's a really good one to talk about because it's sort of impossible. It's so extreme that you can often think about it without a ton of emotion. And it's a useful thought exercise. I think it's useful for everybody to think about what they want. And some people, including me, I'd say, leave me on some machines for 5 or 6 days. Let the swelling in my brain go down, see what happens. And then reassess. And if they say, no, PVS, then it's like, pull all those plugs. Pull them. Kiss me goodbye. It's hard when you're talking to my husband. It's very like, Lisa, you have to promise me you'll pull the plug. I'm like, okay, I'll pull the goddamn plug. You know, it's hard. It's hard, but it's really important because every one of us is different, and you may not all want to do things the way I want to do them, and the person for whom you're proxy might want to do things differently than you would want to have done for yourself. So we cannot make assumptions about what other people want because everybody's different, and that's part of what makes us interesting. And also, everyone's at a different phase in their life, right? And in your health trajectory, you're all at different phases. So, you know, if I had a terminal cancer diagnosis, like my cousin who's barely just my age, she's 61 and she's got stage 4 lung cancer. She is on hospice and she is do not do anything, okay? Whereas 2 weeks before her diagnosis, she was a full code. All right, so stuff changes, and if it does, that's your cue, among other things, to revisit how do I feel about my MOLST form? How do I feel about all of these possible interventions? And do I want to be nuanced about them? You can't be nuanced about CPR. They either do it or they don't. They don't go part way. You know, my dad, when my father, toward the end of his life, he was full code and he really needed not to be, and the doctor said, all right, let's talk about this. And she said, I think it'd be better if you're DNR. He said, well, couldn't they try for just a little? It's just like, no, that's not how it works. It almost makes me cry thinking about it, because it was like, well, maybe, you know. But at a certain point, the last beat of your heart is meant to be the last beat of your heart. It's a sacred, sad, lovely, I mean, our hearts have been beating since long before we were born. It's kind of darn miraculous, I think. So at a certain point, it stops. And I think that's one of the most important things that we have to come to grips with here in this room, talking about these issues, is that we're all going to die someday. And at least up till now, you know, that's the natural way of things. Maybe it'll change. Maybe we won't have to die in the future, but we do now.
Can I ask,
Please.
what is the difference between intubation and ventilation?
Okay.
Non-intubate and
Okay. Good question. So intubation is a tube that goes in.
is the inserting of
Is
the
a
tube?
turning of a tube. And then the tube alone isn't going to do it for you. You need a machine that's going to pump air into your lungs, inflate them, and that's going to breathe for you. Because let's say your lungs are too weak, maybe your ribs are too weak, because that's how you normally breathe. You expand your rib cage and the air just pours into you, because it's like a vacuum. It's not what we think, but that's how it actually is.
Negative pressure.
Right.
So the
Some
end
people,
ventilation is...
the non-invasive ventilation is like a CPAP machine. So
Okay.
somebody who needs a little bit of help, could end up with a CPAP. Now, how many of you have used a CPAP?
Yeah.
Yeah, you have. It's not the most comfortable thing in the world sometimes.
it's
Those
not.
masks, they're really tight and they're straps, and so it's better than a tube down your throat, right? And so for some people, they could have what is called non-invasive ventilation. That's one of your choices. So if you thought about it and you thought, well, intubation sounds horrible, there's no way I want that, but try CPAP. And you could tell your healthcare proxy, and you can actually say it on the back. Turn the form over. There are other, you can get more detailed. So look at the top one. It says, use intubation and ventilation as checked, but short-term only. And then it says use, or you could say use non-invasive ventilation, but short-term only. And what does short-term mean? You and your healthcare proxy have to have a discussion about that. It might be 4 days. It might be 2 weeks. It might be until I rip the damn thing off my face because I can't stand it anymore. You know? Everybody's different. And the great thing is you don't have to decide. None of this is engraved in stone now. This is just where we start for the foreseeable future. That's what advanced directives are. They're for the foreseeable future. So for me, I feel like my foreseeable future, if my health status doesn't change much, if I don't get some crazy illness or develop diabetes or something like that, I could see for the next 10 or 15 years, I personally probably won't need to make that many changes to my advanced directives and to even fill out a MOLST form. But as soon as something happens, like you're diagnosed with AFib and you have to start going on a blood thinner and that, you know, or you have congestive heart failure because you've always had a weak heart and now it's just, you know, in between the summer weather and maybe you get pneumonia and then everything, you know, there's this vicious cycle of things that happen. That's when you have to revisit these things and say, okay, where are we now? Do we still feel the same way about CPR? Do we still feel the same way about ventilation? And keeping in mind those statistics I read, the percentages I read to you, as we and or our loved ones start hitting the 80s and the 90s, you know, if you're a frail elder, there's no cure for frailty. Frailty is frailty, you know? And you can be fine for a while, but it's different. Like, how many of you watched the royal wedding last weekend or whatever? Prince Philip? What a badass. 96 and just 6 weeks since his hip surgery. Look at, I mean, some would say this is idiotic that a 96-year-old gets a hip replacement. He's a modern miracle. I mean, he has, I'm just in awe. He's in great physical shape. So for him, great idea to do the hip surgery. He was walking without a walker, without a cane.
Oh, yeah,
No, he didn't. Not in the church. No cane. He's been practicing going up and down steps, like with his iron will, you know, like, damn it, I'm not going to have a cane on international television. My jaw dropped. I was like, you go, guy. But not everybody is Prince Philip at 96, are they? So electing whether or not to have surgical interventions, that's not on the MOLST form, right? But that's something you really need to think about. Just because it's suggested, just because a doctor says, well, your mom needs a hip surgery, doesn't mean she'll survive it. It doesn't mean that her dementia won't get worse as a result of the anesthesia. It doesn't mean that she'll ever walk again. It just means that medically, for Dr. X, Y, and Z, it's like, well, logically, this is the next step. And you could be looking at your mother and thinking, are we looking at the same person here? Like, are you nuts? I mean, I think this way all the time about doctors' decisions. I work in a cardiovascular practice, and there are times when it's like, you really want me to put a monitor on a man with diagnosed AFib who's 92 and demented, and it's like, knowing whatever you find out from this monitor will change nothing. Like, so invasive tests, you need to ask yourself, what do we do with these results? Am I going to do anything different knowing these results? And if not, then why are we having the CAT scan done or the x-ray? And sometimes you have to stay up and be the voice of reason and say, no, thank you, Dr. So-and-so. They say, but she needs a CAT scan. She's like, no, thank you. And that's your choice. But you have to be strong sometimes, right? We talked about this, the feisty, mouthy healthcare proxy, because as long as some medical person thinks that there's hope from doing the next test or the next procedure, they're gonna offer it to you. Here's what we should do next.
Some people won't.
And some people want everything done. Okay, so that's the question that I just heard myself say that I think is insidious. When, let's say, your loved one is about to go into surgery and the doctor says, okay, well, if his heart stops, do you want us to do everything? How the hell are you supposed to answer that question without feeling like a total heel, right? No, I don't want you to do everything. I want my mother to die. I mean, it's like, but it's a terrible question, and it makes it really hard for the healthcare proxy to advocate on behalf of their person, the way they know their person wants to be advocated for, right?
At the 11th hour.
Yes.
In front of them.
It's always at the 11th hour. This is another reason why it's so important to think about these things ahead of time. Because if someone says, okay, and we have to go down to surgery in the next 20 minutes, we're prepping the OR, what's your decision? And you've got 5 minutes to decide. And it's life or death. Well, the fact is, we've known our whole lives that we're all going to die, so there's no excuse to think like, what do you mean, mom's going to die? It's like, yeah, she's always been going to die. I have no patience. Sorry, I'm a long-term care nurse. I was for 6 years, and the son of this 104-year-old adorable Polish lady on our unit, she's 104, still walking around with her walker, just a little bit demented, cute as a button. And finally she had a couple of little strokes and she was just slowed down, and her son, who's almost 80, comes in. He's her healthcare proxy, and he's like, whoa, can't we do blah, 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 blah. And I looked at him, I said, just how long did you think your mother was going to be alive anyway? And he kind of was taken aback, and he tilted his head to one side, and then he smirked to himself and smiled. He says, I guess you're right, you know? But she was his mommy, right? Even though he was close to 80, that's his mom. And it's like at a certain point you have to shift gears in your thinking. And that's hard to do because no one helps you do that until about 12 minutes before it's time to say, no, we're not going to do any more interventions. And that's a problem with hospitals. It really is. They'll keep pushing the options until they realize, oh, we've hit all these dead ends. Now we're done. You've got 24 hours to say goodbye. Call your loved ones. So you're like, wait, yesterday you were going to do the CT scan, you were going to do the surgery to remove the lung, and now you're saying 24 hours? This happens all the time. It's just the way medicine works. To expect it to work otherwise is delusional. So you're hearing it now. Hopefully, you know, it sticks in all our heads, including mine, because in the heat of the moment, it's really hard to hear what you need to hear, to ask what you need to ask, to decide what you need to decide. It's really, really, really hard because you're talking life and death about people that you care about deeply. And that's why we do it sort of, you know, not in the heat of the moment because we can actually think about it. What were you going to ask?
I was going to say, going back to Prince Philip, he has help at home.
Right.
I mean, I find myself, this is an issue.
It has for a while.
He
I'm
does.
saying, I'm giving up a volunteer activity this year because it involves tramping around in the woods and whatnot, and I admit it's a little buck. If you don't have anybody there and your family is 3.5 hours away, that makes a difference in what.
Okay, so you bring up a really good point, a couple of good points. One of them is about healthcare proxy. It's really good if at least one of your healthcare proxies is close by and not 3.5 hours away. So maybe that's a trusted friend, a neighbor who you get along with well and you've had these conversations with, who's willing to be the alternate in case, in case your child or your whomever can't get there right away. Now, you can do things over the telephone too, but a body in the room, watching what's going on, is always the best case scenario, if at all possible. That's the gold standard for healthcare practice, right? Because stuff happens. Change of shift, and the new nurse hasn't gotten the right information from the old nurse, or the hospitalist who's on duty at night says one thing, and then the hospitalist who's on duty on the day says another, and the lines don't, you know, and the healthcare proxy is the one who's holding it all together. Because they're the one who really cares. They're the one for whom it matters the most, right?
Well, it's true though. Yeah.
Because they're filled in.
It's absolutely true.
So, as far as CPR goes, physicians tend to overestimate the likelihood of survival of CPR done in the hospital. They tend to think, oh, this is a good idea. She'll go back home and she'll be fine. The literature, so this is like journals of medicine, say that survival is 6.5 to 32%. So an average of 15%. So people in the hospital are what? They're already sick, right? And so CPR is just not gonna make the sick go away. At least 40, almost half of the survivors will have a significant decline in functional status. And sometimes that's including mental status as well. And I don't know, has your mom had surgery where you seem like she's like a slightly different person after the surgery?
No, she
Anesthesia
never
for
has.
someone with dementia
She
can
has
really
dementia.
can really take it down a notch. And you know, like even just as simple a thing as having a pacemaker put in, and pacemakers, we could spend an hour talking about them. Because that's one of those interventions that, you know, when it's good, it's very, very good, and when it's bad, it's not. Like the little girl with the little kernel in the middle of her forehead, right? But you have to be put under to have them installed. And just that anesthesia alone can cause a decline in mental status. So, and a doctor isn't necessarily going to tell you this and say, okay, you need to think about whether you want this procedure done because anesthesia can have this effect. We have to educate ourselves. Because guess what? Guess who's really bad sometimes at dealing with death? Our doctors. Because it's a failure for them. They want to keep patients alive.
So isn't that would that be in the informed consent now that you signed before surgery that would say this could be one of the complications?
It could, but how many people read carefully?
Yeah.
It's like the teeny little writing and they're just like, oh, sign this. I'd be surprised if your typical anesthesiologist would sit down with you and say, okay, your mother's sort of halfway through her dementia process. She's at like stage whatever out of whatever. Here's one of the possibilities of full anesthesia. We saw it all the time in the nursing home. I worked on an Alzheimer's unit. Saw it all the time. But families either don't hear it, they're never told it, or they don't want to hear it. Right? But it's an important thing to keep in the back of your head. You can say no. You can say no to all kinds of things. You can say no to antibiotics. They're not on here. Antibiotics, not specifically, but that's something else that you can say, okay, not this time. This is the third aspiration pneumonia. Now we're not, you know, like we treated the first 2 times. Now we're done treating. We're going to keep my person comfortable. Maybe that means hospice or palliative or whatever. They're going to be really comfortable, pain-free, maybe come home, but no more antibiotics. That's a valid decision to make, and that might be aligned with your person's wishes. Okay? So it's not on the MOLST form. So what do you do if you feel like I might want to have that be one of my wishes? Well, you can. Now they have this lovely minute little space here that says other treatment preferences specific to the medical care on the B side, right?
Mhm. 3 1/3
It's
line.
paltry. There's no room there for anything. But you could write a page of stuff out that's specific. It doesn't help to say generalities because we are nuanced, we are complicated, and so many different little scenarios can happen that you couldn't possibly foresee. And if you wrote them all down because you were psychic, nobody in a hospital would take the time to read the 15,000-page tome of like, oh, where's the thing about intubation? Oh, here. Not going to happen. That's why the healthcare proxy is so valuable, because you'll know this stuff. And if you don't know, you'll ask questions until you feel confident about making the decision. And you should never feel shy about saying, one more time here, I want to understand. Quality of life. How does this affect the quality of life? What are the chances for my loved one? We talked about this with Julia Child because I had just finished reading a wonderful memoir about her. She lived to be 92, and she had to have dialysis, and she had a port for her dialysis, and the port became infected. She became very ill, and they realized she was septic, and that means that the infection is all through your bloodstream. And the doctor said, we have to treat you or you're going to be dead in 48 hours. And she said, And now she didn't need a healthcare proxy because she was clear in her head. But a healthcare proxy could just as easily have made this decision on her behalf. And she said, can you guarantee me that I'll be back to sort of my old self once I have this treatment? Not fully cured, but just, feeling good again and not sick. And he said, no. And she said, okay then, don't treat me. And she died 2 days later. At peace.
I have a question.
Yes.
7 years ago, 7 or 8 years ago, when my father-in-law was 93, this was 7 years ago, he had a hip replacement. No, that's not right. He had the pins and metal and all
Okay.
that stuff. He had fractured his hip. And he had a DNR. This might have been pre-MOLST, and I'm sure he did not have a MOLST, but he had a DNR. And in the emergency room,
Did they revive him on the table?
the physician came in and said, you have a DNR, do you want to be revived? And he said, of course I want to be revived. So it was switched.
Here's the thing, they might have been talking about during the surgery. Very often, surgeons will refuse to do surgery
That's right,
if someone has a DNR.
that's right. It doesn't look,
Well, no, but because people's hearts can stop. And
right,
because of, a blood clot, or, you're cutting into bone, and it could be a bone, what do they call, fat embolism from long bone fracture kind of things. So you could temporarily suspend your DNR. If I were having surgery, again, for a 93-year-old, then maybe it's like, well, I don't want to do the surgery. And sometimes you need to, because it's actually more humane and comfortable to have the surgery, because it's keeping your bones from grinding against each other.
right.
Sometimes there are other options that one can explore, though. So sometimes these things are presented in black and white, either or kind of choices, and sometimes there are other options available if you push enough.
So it's always a fluid situation, you can always change
It
these
is.
things. See,
They don't like it.
That's what I misunderstood.
They-
I thought he had a
this is-
DNR. He had a DNR. Why did the doctor come
Suspended
in
it.
and
Because
say?
probably because he was talking about during surgery,
Right.
if your heart should stop,
Right.
do you want us to revive you? And you
He said, "Of
can
course."
do and undo your MOLST as many times as the cows come home. All you need is for someone to sign it. You need someone who's willing, a medical person, a nurse practitioner, an osteopath, or a doctor has to sign it.
Or PA.
Oh, a PA can sign it too. So if you wanna change your mind and have it, decline, add more stuff, or maybe take something away for a brief amount of time and put it back, who cares what your reasons are? They're your reasons. You don't have to explain them to anybody. You might have to deal with some rolled eyes. Like, I want to change the MOLST again. You're like, really? It's your right to do that
Right.
for your loved one. But it seems to me that some more questions could have been asked at that point. Like, why are you asking me this? What do you mean are you just talking about during surgery? Are you talking about
Right.
from now moving forward? I mean, it's kind
It
of
just seemed very strange to me.
yeah. And it almost seems a little like
Well, it was 11th hour.
yes. Well, healthcare is all about the 11th hour.
Right. That's true.
And unfortunately, sometimes as people dement, they don't think the same way they did when they were fully in, so they can change everything. That's another good reason to invoke healthcare proxies when it's appropriate to invoke them. All right.
So that happens, excuse me though, but doesn't that happen a lot? If someone's facing surgery and they have a
Yes.
DNR and they want the surgery because otherwise they won't walk again, perhaps?
Right.
I don't think that's so unusual.
It's not unusual at all with surgery
Okay.
for a physician to request that, but then you would really want to switch it back again once they're done with the surgery
Right.
and not have them stay full code. I mean, that could be really awful, right? And a person could assume, well, I'll go back to I'll go back to my no code again. No, that's where a healthcare proxy or the child or whomever can really be helpful to just say, hang on, I just want to see what forms you have now, what's in place, what's my dad or my mom's code status now. Hospitals know from code status. If you ask them, they'll tell you, because they're very interested. That's one thing they really want to know.
Wouldn't another part of that be that for the family, they wouldn't want someone to go in surgery, person's heart stops or something happens and they come out, oh, the surgery's successful, but your father died. So this way, I think part of it would be for the emotionality of the family to think, okay, he's having the surgery.
You mean to suspend the DNR during the surgery. And it really depends,
You know what I mean?
what shape was his heart in, because maybe he's having his hip pinned, but maybe he's also got a really weak heart, Then you might have a different, everybody's situation is different. You have to weigh all of the pros and cons. But if someone has a really strong heart and they just have weak bones, then you're like, well, I don't care if she's 93. Let's say, yeah, if her heart should stop, we'll do, shock her or whatever they have to do so that she survives surgery. And then once she's out again, then we'll have another one of these ready to go. So the doctor, one of the things that has come up with me in other talks about the MOLST form is what happens with dementia. And very often you can have these discussions about certain end-of-life scenarios and think it's all settled with your doctor, but then it turns out your doctor actually doesn't agree to do what it is you want. So you really need to ask specific questions. Or maybe the hospital is a Catholic hospital and it says we don't pull feeding tubes. Or maybe the long-term care facility says we feed all of our patients. It doesn't matter if you say you don't want them to be spoon-fed, we're going to do it. That's what we do. So you need to research that ahead of time so that you're not surprised by, well, I thought I could have whatever I wanted. No, they don't have to, no one has to consent to do anything that goes against their morals, up to a certain extent. Like a doctor doesn't have to perform abortions who doesn't want to perform abortions, even if they're legal still, thank God, in some places in the United States. So it's good to know if you want an intervention or to not have an intervention, whether your doctor is on board or not. Because if they're not, you need to find a different doctor. Or maybe you need to switch to a different facility, a different hospital, or a different long-term care facility. Sometimes these draconian measures are really necessary, right? But don't get into a fight with that you're never going to win. You have to figure out, is this just a disagreement, or is this them saying no, not going to happen?
Can I just clarify something?
Please.
See if I understand. So, a healthcare proxy is an advanced directive, meaning that it's something that's turned off until the physician says it's turned on. Whereas the MOLST, once you've filled it out and had it signed, it's in place and it's ready to go.
Correct.
Is that correct?
It's like a prescription.
Right,
That's
exactly.
good starting as soon as
Because it's a medical order.
It is.
It is.
And so for people who are full code, there's no need to fill this out because you would just be saying yes. You wouldn't be filling anything.
Right.
You'd just be saying do everything that I might need. So there's no point in filling it out unless you want to say no to any of these things.
So the healthcare proxy is not invoked until the physician deems the patient unable to make his or her own medical decisions.
And it's usually not controversial at all. If you feel like, God, Mom really, the short-term memory's gone, she's not comprehending the way she used to, you can say, I want you to invoke my mother's healthcare proxy, and usually they will. I mean, they're not going to invoke it on, like me, because I'm still mouthy and in full control of myself. You don't have to worry that it could get turned on and have your authority, your own authority to make your own decisions taken away. But you don't have to wait for some doctor to notice that your mother can't make decisions anymore. You can kind of say, I think it's time.
Okay. And if it isn't invoked when it needed to have been invoked, that sounds like that would be a real mess.
Right, but it can be invoked immediately
Okay.
because you have it in place. The mess is if you don't have the healthcare
Right.
proxy form.
You don't have it in place.
That's the mess. But it's just a matter of like a few seconds. Like they fill out a pre-filled form, they put her name or his name and their name and they sign it and boom, it's invoked. And now you, if you wanted to, if you needed to, you could fill out a MOLST form on your person's behalf.
Okay.
So
But I mean,
there's-
she already did. I mean, hers is like,
Don't do anything ever.
yeah, don't do anything ever.
Right, but you know, there's don't do anything. Sometimes there's a reason to do a little something. Sometimes there's really good reason. And there are times, I can just say, there have been times people who've had living wills, which by the way are no longer a legally binding document in Massachusetts. They haven't been for a number of years.
Right.
They can be instructive for your healthcare proxy, but they have no legal sway at all. But there have been people who say, don't do anything, you know, I don't want to be hooked up. And they're 47 and they needed to be on a vent for 3 days so they could watch their grandchildren grow up, and instead the hospital's like, well, it says not to do anything. And then, so it can backfire on you. And that's again why having a healthcare proxy who can think on your behalf in a nuanced way.
But you can't overrule.
Who?
I mean, my mother's 92 with dementia that's advancing.
Mm-hmm.
So, I mean, and I'm pretty sure, I mean, I was realizing we need to look at it. I'm pretty sure it says don't do anything.
Okay.
So, I mean, we couldn't overrule that.
Absolutely you could. If you're an invoked healthcare proxy, you can do whatever you want.
But it's not been activated.
No, it hasn't been, but if it was,
Well, it sounds like it could be.
it could be. I
If
think
she's
it-
dementing, just ask her doctor to invoke it. And it doesn't mean that she can't still be part of the decision making. But,
Right.
you know, at a certain point it will have to be invoked. Sounds like. I mean, I think everyone at Charlene Manor, I worked at the locked unit there, the Alzheimer's unit. Virtually everyone on that unit had an invoked healthcare proxy. Very common. Even the people who you'd meet and you'd think, wow, they seem with it. What are they here for? But they had an invoked healthcare proxy. So, and it doesn't, of course you care about your mother. It's not like you're going to ignore her or not ask her to the extent that she can participate in the decision-making process, but it just means that a little more analytical mind is going to be doing things on her behalf the way she'd want them done.
Right.
And there are times when you can have wonderful quality of life doing, like I talked to someone the other day, her mother's pretty demented, but she had like this major valve thing. They did a clip on the valve. I don't even know what that is, but it saved her life. And they do it, they just go in through a vein. So it wasn't like it was open heart surgery or anything. And those clips, it's like her heart functions so much better. She's oxygenated. She's still beating everybody at gin rummy. I mean, she has no short-term memory, but she can play gin rummy till the cows come home. So some people might argue, you know, I wouldn't want that, but her mom's really happy. So sometimes an intervention isn't always a bad thing. Sometimes, let's say you have a tumor that's pressing against your air windpipe, and you can't breathe very well. Well, even though you might be against surgical interventions, it could be that surgically getting rid of that tumor would mean, oh, I can finally breathe freely, and you'd have a much better quality of life for what's left of your life. There is an
It's
option.
microdacting, you shouldn't consider that it's a cure.
It's not a cure, no, it's palliative. It's there to help you feel better. See here, option C, do not transfer to hospital unless needed for comfort. So everybody's version of what's comfort is different. But if my loved one couldn't breathe, and the morphine from hospice only did so much, and they're, and they're freaking out because they're panicking, I think I'd want them transported to the hospital to get some serious intervention for, maybe not intubation, but just to really be in a clinical setting where all kinds of help is available to get them feeling less panicked, to feeling more comfortable, and they can come back home again. That's what my very good friends happened with her mother. She went to the hospital. They did exactly what the family wanted. She was on hospice already. She came home and she died a few days later with hospice, very comfortable, and exactly, it couldn't have been any more peaceful or beautiful. But she had an emergency room trip 4 days before she died. You know, that happens sometimes. It's not a failure. It's just like when you're planning the birth of your children and you're like, I want natural childbirth and blah, blah, blah. Well, sometimes you end up with a C-section. Sometimes you end up with an episiotomy, you know. But do you have a healthy baby? Hopefully, yes. And if you do, then you tend to forget about all that other stuff. And it's like, you know, I was hoping for this way of doing it, but it doesn't, we don't always foresee these things. And birth and death are very, very similar. They're both transitions. It's just with birth, we're on the receiving end, and on death, we're on the sending end, you know? So you try and plan as best you can, and then you have to be open to the little detours and the little issues that pop up along the way. And I firmly believe that the more prepared you are, the more you think about it, as unpleasant as it can be sometimes, the easier it is then to make the decisions when the time comes. And you'll feel better. I think it lifts a burden from the healthcare proxy when they know exactly what you want. When they're really clear on your wishes. So even if it's a hard decision, they know it's the right decision. I mean, the worst is if it's a hard decision and you're wondering if it's the right decision, you know? And lots of people are thrust into that situation. And it's avoidable if you talk about it frequently, you know? Or talk amongst yourselves. Maybe your mother isn't at a point anymore where she can really articulate things, you know, on this level. But you guys can talk to each other and to other family members and get input and support. And the Google is amazing. I mean, you can look anything up on the internet to find out whether a decision you're making seems to be a good one or not. All right, so is it clear to you that ventilation does not mean an O2 tank with a little, you know, nasal cannula? Intubation is a serious, invasive intervention. Life-saving, but very uncomfortable for some people. You can't talk, you can't swallow when you're on a vent. And that might be a deciding factor then, knowing that, you know. A lot of people think, oh yeah, ventilator, you know, give her some oxygen. Like, no, that's not exactly what we're talking about. And by the time you figure it out, they're on the vent, and then it's much harder to undo what's been done if you realize that may not have been what grandma wanted, or mom, or dad, or something. All right, I asked you to write down questions. So one of these is, why shouldn't everyone have a MOLST form? Is it clear to you why maybe not everyone in this room needs to fill out a MOLST form yet? Right? Because you might be full code. But as soon as you're no longer full code, then talk with your physician and check off 1 thing, 2 things, 4 things, however many you think you want to check off, and sign it and have them sign it, and then you've got your first MOLST form. And then you need to keep it someplace. You can make multiple copies of this, have one in your glove compartment, put one up on the fridge, and or the back door, you know, the side door where the EMTs are likely to come in. Give one to your healthcare proxies, along with the healthcare proxy form, because they're the ones who might be saying, here, I've got paperwork for you, depending on where you are. Hospitals try to do a good job, but stuff gets lost. You know, it might be at the back of the stack of things in the chart, and the doctor's just not going to go looking for it. They just don't. So don't expect them to. Just plan to have the healthcare proxy be there and say, just want you to know, my mom's do not resuscitate, or do not intubate, or whatever it might be. To remind them, if they say, really? And you say, yeah, really, here it is. And you don't have to have an attitude like I just did. So the second part of this question was, should a healthy 90-year-old have a MOLST form? Depends on if you're a full code or not as a healthy 90-year-old, and you might be. If you're Prince Philip, good Lord, he's like the bionic man. I just can't get over that guy. I'm a little obsessed with royalty. I watched The Crown and just, so it's really not about how old you are. Sort of like when you buy a used car, it's not about the age of the car, it's how many miles are on it, right? And does the engine work, and are the tires in good shape? You can have a 10-year-old car that's actually in great shape because it hasn't been driven much, right? Or a 20-year-old, whatever, right? So there's a difference between a 60-year-old who's got diabetes and smokes 2 packs a day, and an 85-year-old who takes 1 pill every day and goes for a walk in the garden and stays active, you know? There's a huge difference. And I would say the 85 or however old I made her, in this case, is in much better shape than the younger person, right? Should you do a MOLST even if you're not unwell? So, I think this is a similar question to the last one. No, it's not appropriate for everybody to fill one out. Is it, however, appropriate for everybody to have familiarized themselves with what's on here? In my opinion, absolutely, because it's like the keys to the kingdom here. It's like the secret, it's an open secret. All the doctors and nurses and EMTs, they know what full code means. But I don't think most people realize when you deliver yourself to the doors of a hospital that you are saying yes to full code, unless you state otherwise with an official medical order. You're saying yes to all of it. So don't be surprised if they say, well, let's do this and this, you know, this is where planning ahead is really helpful. And fortunately, you could, let's say you get delivered to the hospital because you fall down your basement steps like I did. And maybe things, you know, I fell down last year, I fell down my whole basement steps, didn't break anything, didn't break any teeth. I could be dead. I could be paralyzed. If I were paralyzed, then I'd be having a MOLST form filled out, right? That would change a lot of things. And if I couldn't do it, my husband would do it for me because he knows what I want. So that's the great thing about having a healthcare proxy. I wouldn't have been ready to fill out a MOLST form. I'm still not. It's not appropriate for me to fill one out right now, given my health and my wishes. But if you have a traumatic event, it might all of a sudden become very appropriate, and then your healthcare proxy can do it on your behalf. And they don't have to explain it to anybody. This was conversations between you and them. They're going to fill it out based on their best effort to carry out your wishes. Okay? And they can do that as often as they want. I think that's really important information to know, because otherwise you may feel like, oh, I missed my chance to fill out the MOLST. If you have a healthcare proxy, they can fill it out for you. And they can change it as things change for you, which I think is also very important. Do you keep copies of the MOLST form spread around, like with the healthcare proxy form? If you filled one out, then yes, it would be great for your healthcare proxy to have a copy of it, right? It could save a few hysterical moments of wondering where it is. You just double-sided copy the darn thing.
Does that have to be pink?
It doesn't have to be, no. But if you want to get EMT attention, and every state has a different color. In Florida, it's sunshine yellow. It is. That was my mother's. It was bright yellow. This just, you know, it's an obnoxious color. Really catches the eye. And I don't remember with EMTs if it has to be pink in order for them to stop, to cease and desist. If they're, because it's really, they're so, they love their work. They're good at it, and they want to get to, because time is everything. You want to keep that brain from damaging. You want to get oxygen circulating. I mean, they have a mission. They really do. So I don't think we can fault them for doing the job that we are calling them to do. Right? So if you're calling them, have the form. To what extent can you tailor your wishes beyond the obvious listed items? Okay. like I said, there are some nuances on the second side. You can also append an additional list of wishes or orders. That would be as much for your healthcare proxy as anyone else, because they're gonna speak with your mouth, essentially, with your words. And sometimes they need a little reminder in the heat of the moment. Like, remember, here's what I said. I wouldn't expect a doctor to necessarily read a long document. But the healthcare proxy is gonna have time sitting there in the waiting room, and they're gonna know what to say and what to ask. So even if a physician doesn't necessarily even look at it, it's a great way for you to crystallize your thoughts, and it's really important for your healthcare proxy to have, because it's like you're speaking to them. How binding or legally enforceable are the forms? Medical order. If they see this and ignore it, you can sue them. And people have been suing hospitals for resuscitating their relatives when there's an obvious DNR on file. You know, so they're starting to pay attention to that. I mean, you'd rather it didn't come to you, right?
You really have to make sure that it's signed, right? Or it's
You
not
do.
signed.
You have to make sure that it's filled out exactly properly, and that that everything is, that you have the legible printed name of the signer, the date, the telephone number. Just like follow the damn directions. Really make sure that it's all filled out exactly, because they can say, oh, it wasn't filled out exactly right. And if you're not sure, ask at some point when you go to a hospital, or ask somebody, is this filled out correctly? It'll be a good thing to find out before you need to make use of it, right? Why shouldn't everyone have a MOLST form? Oh, we already did that one. Okay. Are there any other questions that you have?
Do you know if the EMTs and paramedics now carry CPAP machines?
I don't think they do.
So it would really be the hospital.
Right. I think they'll intubate somebody who's needs an airway, usually when you're unconscious or something, and that can happen if you're in cardiac arrest sometimes.
It's interesting that they don't, because they're so tiny, you know, the travel.
The CPAPs?
That are great, you know.
You know, I feel like it's like they don't want to mess around.
Yeah.
They're going to put in a big bore needle. They just
Yeah.
want to be able to push all the fluids they have to push. You know, they're not into nuance. It's just, yeah. But hospitals, I know that Franklin has them, because when I was in nursing school, I took care of somebody who had non-invasive ventilation. She didn't like it particularly, but it's available. Most hospitals have it. If it's on this form, you'd have to think it's available, right? Okay, so I'd like us to talk a little bit about the artificial nutrition thing. That's a feeding tube. That's a really contentious, difficult issue sometimes, because food is love, feels like an essential. It doesn't feel like medicine, right? And when you withdraw a feeding tube, people say, oh, you're starving your grandmother to death, and that's a horrible way to go, and how awful. There's a lot of misinformation flying around, and a lot of emotion, and there's a lot of religious sort of moral flavor to the feeding tube issue. And it was the issue with Terri Schiavo and Karen and Quinlan and Nancy Cruzan. It was all about feeding tubes and when they could be withdrawn and if they should be withdrawn. And like I said, Terri Schiavo's was taken out and put back in 3 times over many years. It was just a horrible circus. And because the parents were arguing, oh, she's not really in a persistent vegetative state. She's really fine. And you look, she can recognize me when I walk in the room. And when they finally did the autopsy, she had like 50% of a brain. And it was very, very clear, medically speaking, that she was not a functional human being anymore. You know, that she couldn't swallow, she couldn't speak, or she wasn't awake at all. But
What happened to her Jimmy Baxter? I don't remember why.
she had, she was on some kind of weight loss thing, and she had a spontaneous cardiac arrest, I think. Nancy Cruzan was in a car accident. and fell face
No.
forward in a water-filled ditch.
Ugh.
And so she was without oxygen for 15 minutes.
Oh.
And Karen Ann Quinlan took Quaaludes and alcohol at a party
I
and
remember her.
lost consciousness. Yeah.
That was big.
She was the first one in the 70s. And her parents just said, take her off the vent. But they left the feeding tube and they wanted her to be able to die a natural death. And she was on that feeding tube for 9 years.
Ugh.
She weighed 65 pounds when she died.
This is-
But they were very Catholic. Their thing was, this is an invasive procedure and this is not what our daughter would want. And it's within the teachings of the church that no one has to tolerate something that's invasive and uncomfortable.
But they kept it in.
Say what?
They kept the feeding tube.
Yes, but not the intubation.
I know, jeez.
Well, it's not what I would have chosen for my child, but, and then Nancy Cruzan, they tried to remove the feeding tube and the hospital refused. I believe it was a Catholic hospital. And then Terri Schiavo's whole family was Catholic, so that played into it. The whole religious thing, not just Catholic, but the whole religious right in the United States really got on that bandwagon and
I
created.
could see how, they're both tubes,
Right.
but,
You're right,
But
and it
there's-
feels like the same thing.
but they feel different. I could
Yeah.
see how they could feel the same to some people, but they feel different. So I could see how that was really hard.
It is, well, the whole situation is hard.
Yeah.
And there's some people who feel like, I don't care how diminished my child is, they're still my child. I want to take care of them, I'll take care of them forever. You know, that was what her parents thought, and her brother. And her husband thought, this isn't what my wife would have wanted. And, you know, we tried for years and nothing helped.
And the expense of it all.
Well, and the expense can be a guiding factor as well. You know, if you say in your advanced directives, I do not want all of my savings to be eaten up by long-term care or, you know, these really heroic measures when I'm not even there anymore. That's legitimate.
Could you distinguish between, I know my mother died at my house, and she came 3 weeks of colon cancer and whatnot. She didn't want to eat, and I had a nurse while I was working taking care of her who wanted her to eat and get better. And finally the hospice nurse said, she's not going to get better, she's dying.
Exactly.
But she had no appetite, and that really amazed me that I'd try something, and you know, she'd eat bread pudding, but then she wouldn't. And it didn't bother her, and I had
No,
never
it
run into
doesn't
that.
bother you.
But water is a different thing.
It is.
You talk about food
You're
versus
absolutely
hydration.
right. You can live a long time without food. I mean, yes, without food, but you can't live a long time without water. So if the idea is I'm done, I don't want to do anything to prolong my life, then you have to stop drinking too, as well as stop eating. And it can be uncomfortable because it gives you a really dry mouth, but there are ways around that. There are mouth swabs, there are moistening swabs. The hospice meds are wonderful. There's liquid morphine, which is like a godsend. I mean, I can perform miracles. Liquid morphine, liquid Advent. I used to be a hospice nurse too. You can really keep people very comfortable and not too zoned out.
So that's the morphine drip, is the liquid.
Not a
No,
drip,
just under
no,
the tongue.
under the tongue.
Oh.
It's liquid. It doesn't even need to be swallowed. It can be absorbed under, you know, in your mucous membranes. So that's a whole other issue. There's the physician-aided death issue. There's voluntary cessation of eating and drinking. That's, or VSED, VSED, voluntarily stopping eating and drinking. Those are all ways of addressing how you engineer the end of your own life. And it's hard when dementia is introduced into the whole mix. Because people who might say, let's say you lived in Vermont and you said, I want physician-aided death, I have this terminal illness, or I'm in a ton of pain, or whatever it is. Once you can no longer take the medication on your own, you can't do it anymore.
Yeah.
You have to be able to self-administer. Otherwise, it's euthanasia, and we don't like that. Right?
Or murder.
Or murder, right. And it's the same with dementia. So if you're too demented to carry through on something or even understand a wish that you had before you were demented, then you can't do it anymore.
All of our productions at GCTV are sponsored in part by Bay State Health, providing the care you and your family need when you need it, close to home. Visit them online at baystatehealth.org. Greenfield Savings Bank. Visit them at 400 Main Street in Greenfield. Call them at 774-3191 or go online to greenfieldsavings.com. Greenfield Community College, providing access and excellence in higher education in the Pioneer Valley. Visit them at gcc.mass.edu. The Hammond Family. The Hammond family are longtime supporters of Greenfield Community Television. New Fortune Chinese Restaurant on the Mohawk Trail in Greenfield. Visit them online at newfortunema.com. Call them at 772-0838 and check them out on Facebook. Real Cleaning Services, cleaning Hampshire and Franklin County since 1972. We don't cut corners, we clean them. Check them out online at realclean.com. Call them at 413-422-1143. People's United Bank, located at 45 Federal Street in Greenfield. You can call them at 774-3713 or visit them online at peoples.com. The Solar Store of Greenfield, replacing fossil fuels and nuclear power one home at a time. Visit them at 23 Fisk Ave. Call them at 413-772-3122 or visit them online at solarstoreofgreenfield.com. Thank you to our sponsors for supporting all of GCTV's productions.